Hello and welcome to Gated Health Podcasts. I'm here today at the AK Studios, and today we're talking menopause, and most particular about menopause and breast cancer. So we have two specialists in the region. We have Tony Branson, one of our oncologists, and we have Gwen Bromley, one of our surgeons in breast cancer as well. So thank you for coming today. It's something that we deal with probably on a daily basis. With me being a breast care nurse, I think we're kind of on the cold face of dealing with menopause side effects with the treatment. So I don't know, Gwen, do you want to start with just how does that occur and how your experience of the patients that you meet on a daily basis?
Yeah, absolutely. So as you say, Caroline, I'm an oncoplastic breast surgeon at Gateshead, and so I would surgically manage a lady's breast cancer. I would do their operation, and then I would see them after they've had their surgery, and as long as they didn't need any further surgery, I would be offering them, if their cancer was estrogen receptor positive, and an estrogen blocking tablet, and an endocrine therapy as we commonly call it. And that is something that would block either some of the estrogen receptors that you have, or blocks the formation of estrogens in your body. And so obviously a lady has gone through surgery, a diagnosis of breast cancer has gone through surgery, and it's a very traumatic time. And then obviously once their surgical journey is complete, I would be prescribing them this tablet to take for at least 5 years. And then I actually see ladies in my follow-up clinic. Usually they've been on the tablet for 3 or 6 months, and a lot of them tolerate it very well, but some of them do experience a lot of side effects. And that may be because they may have been going through the menopause when they had their breast cancer diagnosis, and we may have asked them or advised them to stop any HRT they were taking. Or it may be because the tablet that I had offered them has unfortunately caused them to have some menopause side effects, or some symptoms that we associate with menopause, such as hot flushes, sleeplessness. Some people can also develop joint aches and pains, and so I see it very commonly in my follow-up clinic, and it's something ladies really struggle with, and I think it's something that we can address better as medical professionals, and I guess that's why we're here today.
Yeah, and obviously, Tony, you see patients in a slightly different environment, but yes, probably very similar side effects.
I certainly see a number of the problems that Gwen mentions. I think the first thing I'd like to say, I'm trying to blow Gwen's head up to be too large, is the majority of women with breast cancer are cured by surgery. Cancer is taken away, and actually if we did nothing else, they would be fine. But they are left with a risk of the cancer coming back. And one of the ways that we try and reduce that risk is by the use of the hormone type treatments that she mentions. Another way that we reduce the risk is also by giving them chemotherapy. And these are cancer-killing drugs, but they also can stop ovarian function and therefore produce menopausal symptoms. So both of these things, which I do, can lead to people having menopausal symptoms. Again, I would agree with Gwen that a significant proportion of women are fine and actually feel well and carry on. But a smaller proportion of women really do have major problems, and some of them really terrible problems, as a consequence of the endocrine effects of the treatments we're giving. And I would also agree that currently I'm not sure we're as good as we could be at addressing that. I think slightly part of the problem is we're a little bit seduced by the success that we've had in improving the survival in breast cancer. Since I've been doing this, it's gone up from probably about 50% to well over 80%, and we think, oh, we're doing very well indeed, but there's a cost that's come with it, and that possibly puts us in a bad position. And there's a slight temptation to sort of think we're out there to deal with breast cancer, and I think the important thing is for us to get back to saying these are people who we want to enable to live for as long as possible and as well as possible. And those two things have to be considered, not just one of them.
Yeah, and I think we can be very kind of, one direction with this, and there's other things going on in that person's life, so the comorbidities, diabetes, or whatever that is. So again, I think we've done a few podcasts this morning, and what keeps coming out after podcast is that very much personal aspect of
Yes.
it. You know, we talk about statistics, but behind that statistic is that mother, is that grandmother. You know, there's so many different parts of it where our treatment might influence that quality of life.
Yes.
You know, and I do think we're getting there, you know, and we do definitely take that personal approach, but we need to kind of drive forward with that.
Absolutely. And as Tony says, the advances in surgical care of breast cancer, oncological care of breast cancer, means that we've got ladies who 20, 30 years ago wouldn't have survived their breast cancer. We have got millions of ladies surviving their breast cancer now, and they are living with life after cancer. And we need to make sure that, yes, we are treating their cancer as thoroughly and as effectively as we possibly can, but we need to bear in mind that they want to live a good quality life after their cancer. But also, I think what women at the moment are having to live with is menopause management and side effects, and HRT is everywhere. I don't know about you, Caroline, but it's all over my social media feed. It's all over the daytime television. And so not only my patients are struggling because they may be experiencing side effects from their endocrine therapy, but they also have been told that they can't have HRT, and I mean, Tony, it's not recommended. Systemic HRT is not recommended after breast cancer at the moment.
I mean, interestingly, the evidence around this is not that good, put it like this. The main trial, which people tend to quote, is one called the Habits trial. It was done in Scandinavia 12 years ago, I think it was, and it was started off, and half the patients were given HRT after treatment and half were not, and it was stopped early because of the incidence of what was described as breast cancer events, which weren't Macmillan coffee mornings, I have to say there. So you have to look and see what they were. And the interesting bit is that in the control arm, I think there were something like 9 breast cancer events, and in the experimental arm there was something like 39. But if you look at the breast cancer deaths, there is no difference. And if you look at the people who got cancer that had spread to other parts of them, which I'm afraid does frequently lead to death, it was the same. The difference was in local recurrence of their breast cancer or breast cancers on the other side. So from that evidence, it is fair to say to somebody, if you are having HRT, you are at greater risk of something happening relating to breast cancer. You might say, well, I'm not getting much in the way of symptoms that the HRT will improve, and I don't like the idea of that risk. Equally, you might say, look, my life is a misery. I do care about getting more breast cancer, but if you're going to tell me I'm not actually going to die as a consequence of doing this, actually, that's what I'd go with.
Yeah.
And I think that's the sort of choice that we're not routinely offering people. We're taking a very directive view. We're saying, no, you can't do this, because we could say our job is to stop people getting things, whether they're very bad or not very bad, rather than saying, well, you could get something which you might not want to have, but it might be better than the symptoms that you're having. Now, there are other criticisms of that trial, particularly the type of HRT that's used. There's a lot of evidence to suggest that most of the excess of breast cancer, both in that case and in women who do not have breast cancer but take HRT, is due to synthetic progestogens. Because a lot of HRT is a combination of estrogen of some kind or other and progestogens, and the progestogens are given to protect the womb, because unopposed estrogen carries a higher risk of cancer of the womb. So women who've had a hysterectomy don't need that, and who take estrogen on its own, they actually don't have a much greater incidence of breast cancer. And there is some suggestion that various types of progestogen, particularly normal human type progestogen, do not carry the same risk. Again, the overall level of evidence isn't as strong as it might be, and this is reason really why we should be looking at it more. But I think the major point is we're dealing with relative risks, and for somebody whose life is made unlivable by their menopausal symptoms, a modern modest risk is something they would be prepared to take. Whereas somebody who feels perfectly well, has no great problems, then that's much less of a matter to consider.
And I think, as Caroline says, it's coming back to that personalisation of
Yes.
care, isn't it? So everyone is different, and everyone's expectations are different
Yes.
of their post-cancer journey.
Yes.
But certainly, we've got patients who come to us after they've been on their treatment for 3 months, and as you say, they're miserable.
Yes.
And they've attributed that to their endocrine therapy,
Yes.
because coincidentally they started around the same time. We have to remember that a lot of other things happen around that time as well. They've had their radiotherapy potentially.
Yeah.
They may have even recently finished chemotherapy. Also, they're having their psychological adjustment to their time after
Yeah.
their initial cancer journey. And so, some of the symptoms you could well attribute to that. But there's a definite link between certainly muscle aches and pains with some of the endocrine therapy that we give, sleeplessness, some hot flushes, and so I know you would do the same, Tony, would recommend that a patient has a treatment holiday
Absolutely.
in order for us to absolutely narrow down as to whether their symptoms and their side effects that they were experiencing were definitely related to their tablet.
I think I've done this loads and loads. You stop it, and some of the patients feel miraculously better, and then you have a discussion about what you might do about it. Some of them it doesn't change, in which case you could say, well, it's not the tablets. And it's a perfectly reasonable thing to do. And again, there is no evidence that by stopping tamoxifen or the aromatase inhibitors, letrozole, etc., for about 6 weeks, you don't increase their risk of them getting a recurrence.
Yeah.
If they got a recurrence during that time, they were going to get it anyhow. I mean, God forbid. But and it really does sort of clear the slightly muddied waters.
Yeah, absolutely.
And that is a useful thing.
Yeah.
I mean, another thing to consider is, the symptoms of the menopause go from sort of Gath to Beersheba.
Well, I think when you look at the receptors throughout the body that are influenced by estrogen, it's just...
Exactly. And again, how you deal with it can be, does vary. And one of the big bits is you get people who say, well, hot flushes, I can cope with those, they're not too bad. But it's the vaginal dryness, I can't, getting constant urinary tract infections, and I can't have sex any longer, and all of these things. And in fact, all the evidence we have is using topical estrogen in the vagina. If they're on tamoxifen, is almost undoubtedly completely safe. If they're on an aromatase inhibitor, it's less, but there is very, very little risk, and this can transform people's lives. It's easy to underestimate that problem. It also can save the health service a certain amount of money if they're having constant urinary tract infections.
And then alters, their physical activity, the quality, the stress, which then has its own little risks in it itself.
If you've got vaginal dryness, you don't want to go out and do a long walk, a run, or get on a bike, do you? And I think this is it. So I think there's things that we can do for our patients. I think we can offer them a treatment holiday in order to isolate as to whether their symptoms definitely are tablet linked. We've got other tablets that we can try. We've got other tablets within the same family. We've got other ones that work similarly. So certainly if anyone's struggling with that, they could speak to their specialist about maybe switching. If they don't want to switch, or if they would like to stay on their tablet but they are having other symptoms, I think there's therapies that we can use to target those symptoms, aren't there, Tony? So you've alluded to the management of vaginal estrogen, the management of vaginal dryness and genitourinary syndrome of menopause. And I think the vaginal estrogens, as you say, are perfectly safe, but that's not a message that's out there at the moment.
No.
And patients are really struggling to access vaginal estrogen.
And one of the difficulties is that the package insert, which tells you everything that can possibly happen, right down to being hit by cosmic rays, it does say, if you've had breast cancer, you shouldn't use this, and this is a typical example of people covering their backs, but I think we do need to be clear about that.
I think it's the GPs as well. I think there's a lot of patients, going to, seeing their GPs, and the GPs previously haven't had that training in menopause and breast cancer. And I think anybody who's a GP and listening to this, hopefully they'll have that confidence.
I mean, they do write quite frequently to us, and then we can answer it, and that's quite good. I'm reminded of a very great oncologist, sadly no longer with us, who I knew sort of very slightly at Cambridge and have met a few times since, a guy called Robert Buckman. I don't know if you ever saw him on the television. He did comedy shows as well. He did some very good tapes on communication skills, but he came up with something which I thought was probably one we could use as our mission statement, which is, it's no good making people better if they don't feel better.
Absolutely. Absolutely. I mean,
so I think that sort of sums it up.
Definitely.
It's all very well saying, we've stopped you dying, but you made me wish that I could.
Yeah, exactly. You're now housebound because you can't sleep at night. You're scared about hot flushes in public. You can't bear to, mobilise easily, wear tight clothing because of your vaginal dryness. And actually, we need these patients to live well.
Well, that's it. That's the point, really. And as I think you pointed out, statistics are all very well, numbers are all very well, but it's what behind them that actually matters to people. And I think, another bit you mentioned about lots of different tablets which suit people. There is, whether it's a mythology or whether it's true, who knows, different brands of the various endocrine hormone treatments. People will say, I found this one. Yeah. And that doesn't seem to be the problem.
The pink box worked, but the white box was awful.
And everybody will, a lot of people will say, oh, well, but they're all made to the same formulation. It's all... So, well, that doesn't make any difference. If that's what they feel, and if they're taking the pink box or whatever it is, and they're well on that, but the other one isn't, I think, we should listen to people.
Yeah,
definitely.
It's the small things like that. Patients have had the side effects transformed just by taking it a different part of the day.
Different time of the day.
Something as small as that. I hear that a lot from patients.
And it can help with a certain symptom like sleeplessness, but it may not help with the hot flushes. But taking it in the morning versus taking it in the evening, if it works for you, go for it.
Yeah. No, I think that's it. Another strategy which, again, there is some evidence behind, as you mentioned, it's the aromatase inhibitors that particularly give joint pains. I used to say tamoxifen didn't, because if you look at the trials, it doesn't come up much. But I've seen a few patients where it has. So, again, that's what they say. So that's what's happening. But some people who can manage aromatase inhibitors, they take them, and after about 3 or 4 months, the joints are becoming a problem. And they stop them. And there is some evidence that if you take them in, on and off, that there is still some reasonable benefit in terms of risk reduction. So, you're sort of setting a compromise between what we know and what we don't know quite so well, but there probably is some benefit. And that may be a reasonable strategy to try.
Because I've worked with the clinical trials team on a trial called Rosetta.
Yes.
So we're looking at compliance with patients taking the medications and the many. It's the small reasons. We know that cognitive function, the way that we think on menopause, doesn't work as well. So actually remembering to take the tablet, something as small as that can influence everything as well. And
you're talking about compliance, yes. There are large amounts of data about compliance, which range from, sort of 30% up to 85% or so. So it's hard to know, but there's no doubt about it. There are people who collect the prescriptions, but they never take them.
And I think particularly they looked at as well patients who've had chemotherapy, who become sarcopenic, so they lose a lot of muscle mass. Everything's already antagonised, and then we give them a tablet to then kind of make that worse as such.
The other bit is the difference between, obviously, as I said, the joint pains are more with aromatase inhibitors, and we use aromatase inhibitors in postmenopausal. We don't use them in premenopausal women, in postmenopausal women, because there are a number of trials which do show a benefit. Benefit's not enormous. One of my colleagues said that for the ATAC study, where there's it's enormously significant in terms of a statistically significant difference. But whether it's clinically significant is less certain. She said you can't get a grease Barclay card between the two girls. but no, there is a difference. And also, if we're treating hundreds and hundreds and hundreds of patients by giving them letrozole rather than tamoxifen, there will be some who don't get recurrence who would otherwise. But for an individual patient, how much difference does that make? So if tamoxifen is fine for them, but letrozole is not, you're not actually disadvantaging them greatly in breast cancer terms. You may be hugely advantaging them in terms of their joints. So it is just trying, as we've been saying all along, to individualise what we do. And I guess that then comes down to the how we best address that with patients. Because we've gone from an old model where patients were treated and then effectively medicalised. We took hold of them. We started off by sort of saying we would wrap them in the warm bosom of our care forever, which they felt was very reassuring, and we like doing it because we like being reassuring. And then we just kept seeing them forever, and they would be seen once every 6 months, once every year, and they would have the laying on of hands and be told everything was okay. And we sort of stopped doing that. And we've tended to put it more onto patient-managed review, so they come and tell us. But I think one of the bits we're missing is dealing with the menopausal symptoms. Now, obviously, you are beginning to address that.
So we've been holding some virtual menopause sessions, which are open to all our patients being treated at Gateshead. And what I think what's come from these sessions is that it's been nice, that affirmation. You know, that actually this is real, it's not in your head. You know, that I get a lot of patients who think that they're going crackers. On the tablets, the cognitive function, the way to recall words, if they've got a very responsible job, they're really questioning the confidence to be able to do that. And when you get that room of women who are saying, oh my God, that's exactly how I feel, and I've had that side effect as well. I mean, the power of those women coming together and having those, sharing that, and some of that is just, there's comfort in that as well, but I think for a lot of the patients that are coming through, vaginal problems is one of them, and I think it's maybe because as professionals it's not a comfortable conversation, so it's something that's
I've got a lot of male colleagues who wouldn't even touch on that, and as a female I feel very comfortable talking about it, asking women about it, and actually it's quite often a symptom a woman wouldn't volunteer until I ask them directly, and any symptoms from down below, any vaginal dryness, any soreness, and they'll say, oh yes, actually, and I say, well, that's easily resolved. And I think that's the thing, Tony, isn't it? Ladies, my patients would like to take the tablet that we recommend, that studies have shown will provide an improvement in their survival, or a reduction in their cancer coming back. So they would like to take it, but they develop these symptoms. And so what can we do to mitigate that? So the way I approach it is, okay, so there's some easy quick fixes. So if they've got some vaginal symptoms, we can offer vaginal estrogens. They don't need to take it long term. They can take it for 8 to 12 weeks to break that cycle, improve the health of their vagina, and then they can just maintain the health of their vagina using some vaginal moisturizers, which don't contain any hormones at all. But then there's other medications, aren't there, that we can help to target hot flushes, and the British Menopause Society have provided some guidelines on prescribable alternatives to HRT in breast cancer patients, and that's a really useful spreadsheet. So if there's any fact sheets, if there's any GPs listening, the British Menopause Society have produced a fact sheet on prescribable alternatives. Now, it's almost robbing Peter to pay Paul. It's taking yet another tablet. Potentially, we might use a low-dose antidepressant to help with symptoms. But if a lady would like to continue taking their hormone therapy, their endocrine therapy, because they think it will provide some benefit, and studies have shown it will provide benefit in their breast cancer outcomes, there are things that we can do to mitigate that. And I think that's a really important take-home message. And because menopause and endocrine side effect symptoms can affect every system in the body, we can target them individually. And as you say, there's easy wins, massive improvements in quality of life for minimal intervention.
And it might be forever. Some of these antidepressants that we've talked about, a lot of patients feel,
and it's a low dose antidepressant.
Yes, I think it's worth saying. I mean, certainly again, there is some good evidence for benefit with venlafaxine, which you use at a lower than antidepressant level, and for a proportion of women it works. I think the two things really which come out of what you've just been saying. One is this slight feeling that we have. I mean, a lot of our initial discussions, testing and what have you that go on after surgery are, would this patient benefit potentially from chemotherapy or not? And chemotherapy is seen as the big black bad horrible thing that's going to be put on them with all sorts of nasty things. And then we say, it's good news. You know, we don't think you will get any benefit from this. And then endocrine treatment is almost seen as a free good. It's seen as, we just give you some tablets and everything will be fine. And of course, for a lot of women, that is actually true, and that's fine.
They tolerate it very well.
But for some, it is not. And I think one of the bits which we do more with chemotherapy, less with endocrine treatment, is to try and give people some idea of what the magnitude of the benefit in terms of reduction of risk is. Because, you know, you can see people who are really struggling and, I've been told I've got to take the tamoxifen to keep the cancer away. And when you do the statistics such as we have, you can say to them, well, look, taking this tablet will stop one person out of 100 dying from breast cancer over the next 10 years. And they might say, well, that's not a lot. Some people might, however, say, well, that would be me. Now, those are both perfectly okay points of view, but they're their points of view, and it's not up to us to say, well, I must stop that one person, even if I make your life a misery. Or alternatively, we have to try and get round the misery side of things because you feel that it would do it for you. And I think this is where we've gone from the very paternalistic medical model, although I'm saying because now half the doctors at least are women, it can be maternalistic, but it doesn't matter, but directive model. You come to us with a condition and we tell you what to do, and you can lump it or like it. And there's a sort of halfway or possibly extreme the other way, which I don't terribly like, which is what I call the menu model. These are the things you could do. You choose. The problem about that is a little bit between the lines that says, well, if it all goes horribly wrong, it's your fault. And then the one which I try and practice, emphasis the try, is the shared decision. I know all about the disease and its treatment. You know all about what really matters to you. Let's try and put these two things together and come up with something that best satisfies what matters to you and what I know will help with it. And I think that's the way we can do the best we can in these circumstances.
Absolutely. And you do that in your clinics. Caroline, when you're doing your clinics, you sit down with patients that are struggling and you actually work out on the NHS Predict, don't you? It's a software that is available to anyone, and you can quantify that benefit for patients, and actually it's just really lovely to put it in perspective for them. It
is helpful because
some people think without the tablet I'm going
to die. Exactly. And it is easy from our position. I mean, you know, as medics, we have a sort of position of power. You know, we hold the knowledge or whatever, and we tell you something, and that's what's going to happen. Well, to some extent, we've probably overblown that a bit. We do know a great deal, and we have very considerable expertise in the area, but it's trying to put together that with, as I said, the patient's expertise, with knowing what matters to them. And if we don't share both sides of it, it is easy for them to come away, I've been told I've got to take this.
Exactly.
Or I've been told I can't take this.
And it's also the family and friends around them as well, that, you know, there's an expectation they've given you something, therefore you must take it. And there's a guilt. And like you say, there's a lot of women who are picking up that prescription, but are not actually taking it because their lives are miserable, and you know they would never share that with anybody, because again, a lot of patients in these menopause clinics will say, I feel guilty, I've been told, you know, my cancer is being removed by surgery, it's a very good outcome, here's your tablets, you should celebrate. And you know, they feel guilt that, you know, they're kind of moving that, not taking that.
Absolutely.
Well, almost ingratitude, really.
Yes, exactly. They're not being grateful because we're providing them with the tools. But as you say, it's all relative. Unfortunately, it's all relative, and some patients will benefit significantly from this medication.
Yes.
And if we can mitigate some side effects that they're experiencing and allow them to stay on that medication
Yes.
while lead a really brilliant quality of life, fantastic. That is what my overall goal is. And I will use every tool available to me. But there are some patients, let's face it, Caroline, who actually say, my life's not worth living while on this tablet. I would rather have better quality of life and potentially take a very small risk of my cancer coming back. And I think that's perfectly reasonable.
Part of my involvement in this element of the HRT bit actually was because I was referred a patient who had a screen detected ductal carcinoma in situ, non-invasive cancer, 7 millimeters in size and smaller than a thumbnail, completely removed surgically. But because it was high grade, she was referred for radiotherapy, which is what we routinely do because it does reduce the risk of recurrence, and that seems fine. And I thought I'd just be taken for that. And she said, I was on HRT, I've been told I've got to stop it, and I can't bear it. And the plethora of symptoms that she produced, I won't go through, but they were bizarre, some of them, but they were extreme, very extreme. And we had a long discussion about this, and I said, look, I cannot sit here and tell you there is no risk to you from taking HRT, but I can tell you that it is extremely small. And she then went away and saw a menopause specialist and said, I spoke to an oncologist. She said, the risks of me taking HRT are extremely small, which is precisely what I did. And so Louise then got in touch with me about it. But it was true.
Absolutely. And I think there are some nuances around breast cancer, which we shouldn't expect GPs to be aware of. But I mean, I don't know if we want to briefly cover that, the fact that everything that we're talking about potentially is relevant to estrogen receptor positive cancers, which the majority of the cancers that we see are estrogen receptor positive. However, there is a small subset of cancers that don't contain that don't possess this estrogen receptor. And we know, and we commonly call those triple negative cancers. And unfortunately, on a GP record or on a hospital record, a patient may be simply coded as having had breast cancer, and it's not further subdivided into what subtype of breast cancer, quite understandably. And we know that triple negative patients, they don't possess an estrogen receptor, and so therefore we could safely use HRT in those patients. It does not confer any increased risk of recurrence, as far as I'm aware from the evidence.
No, there isn't. There is no, and that's right. There is no evidence that it does. All of the studies that have looked at HRT, people who've had breast cancer, do not show an increase in recurrence in triple negative cancers.
Absolutely, and the recent meta-analysis that hit the news last year actually. When they removed the triple negative cancers from the analysis, actually it was proven that actually there was no increase in risk on triple negative cancers. So I think we can confidently say to patients
I think we can. I mean, I've had one bit, which was from a colleague, I have to say, who put in a letter and said, no, there's no risk of them getting recurrence, but because they are at risk of another breast cancer which may be receptor positive. I thought, well,
we're all at risk of developing another cancer of another type.
That is stretching it to a ludicrous degree. And
it's empowering the patients, and that's the point of these podcasts. I think being able to say to their general practitioner, I would like to be considered for this, and the following reasons are because either because I'm a triple negative cancer, so therefore that should be the end of it, or because actually I know I had an estrogen receptor positive cancer, however my quality of life or my severity of symptoms is so bad that actually I would like to be considered for HRT.
The interesting bit is that, as I said, in sharing decisions, we're putting together the evidence that we know about, and then we're putting it with what matters to the patient. And that isn't an infinite thing. I think you would agree, and I would certainly, is if somebody came to you with an operable breast cancer, and they were fit for operation, and they said, I'm going to get rid of this by the power of positive thought, you would say, I'm sorry, I can't make you have an operation, but I can't agree to it. I'm not going to share this decision because in my experience this will not end well. And that's all you can do.
Absolutely.
But I mean, everybody has a right to decide whatever they want to do with themselves, but our job is to help them with that decision with the evidence that we have. And of course there does come a point where there's a parting of the ways, but that is so seldom as to be not our frequent experience. But if we would go with them with what we know, we can usually come up with things that are the best way forward for them. They may not be perfect. I mean, life isn't perfect.
There's no silver bullet, and I've had patients who've had those side effects and have just said, we'll give them the options. They've gone through everything. They've tried everything. They're like, look, I'm just ready to call it a day with the tablets.
Yes.
And obviously they have that little bit of, communicate that they have that guilt. But then we look at maybe, right, okay, we're going to take away that tablet. We could still manage a little bit of that risk by, the arthralgia might go down so that you can move more, you can exercise more.
Exactly.
Yeah, maybe to control your weight that little bit better. So all of them are little risks in themselves, which again a patient can then control and think, well, actually, if I'm not going to take that, I'll try and reduce those risks by actually just lifestyle changes.
We know it's multifactorial.
Yeah.
We know that's why some people develop breast cancers and others don't. Sometimes it doesn't make sense. We have these risk factors going on that we don't even know about. But as you say, there are modifiable risk factors, and alcohol excess or the current guidance is less than 5 units of alcohol per week after breast cancer treatment. We know that you're managing your BMI and active exercise regimens, strength resistance training can all improve your outcomes in the long term after a cancer, any type of cancer, let alone breast cancer. And so, as you say, if we put patients in a better state of mind, physically feeling better, actually they're going to be able to empower themselves with those other modifiable risk factors. I think something you were going to touch on just briefly before was when we mentioned about low dose antidepressants. Sometimes patients, there is a bit of a stigma around using antidepressants. It is a low dose. It's used not for depression symptoms. It's used because it has a neurotransmitter, effect on your neurotransmitters. But also, you're not on it long term. No. Sometimes it just takes 3 months of, say, venlafaxine to break that cycle of your symptoms. And actually, everything else that's going on can settle down at the same time. And so it's worth just trying a short course at a low dose.
And I see patients at 1 year. And we have these discussions about side effects and things like that. And the amount of patients that I'll see who say, actually that 3, 4, 5 months, I would nearly stop taking them. And then all of a sudden, a lot of the side effects actually started to plateau.
Yes.
I felt better. I felt like more myself. And actually now, speaking to you today, I feel absolutely fine. And I'm glad I kind of rode the wave out.
I mean, it's interesting in terms of, natural, normal menopause. Women have symptoms that some have no symptoms, some have symptoms that go on for a few months, sometimes symptoms that go on for years and years and years, and there is no straightforward this is how it is, and I think the same can go for that. The other bit I just say about people stopping their tablets before the allotted time, I think it is entirely reasonable and perfectly correct to say is you will have had some benefit. So it's not as if you're throwing out everything, and how much difference the extra, however long it would be, might be, we really don't know. So beating yourself over the head with it, if you can avoid that, isn't necessarily a good idea. And the same goes with chemotherapy. I sort of people have 6 cycles of chemotherapy and they get to sort of 5 and it's rather die than have any more, and you say, well, we only give people 6 because it's half a dozen. If we were more metric, we'd probably give them 5. This is what we have the evidence for.
I thought the oncologists were clever.
No, we're just sort of alchemists really, but it is, I think it is helpful to say things in a way that doesn't instill guilt in people. If they're going to feel guilty, they're going to feel guilty, and you can't. Probably the biggest waste of breath in the whole world is saying don't worry. But but if you say, look, the way we see it is that you've almost certainly reduced your risk by a bit, and you probably will be okay. And to some extent, if you're not okay, it might have happened anyhow.
Totally.
Now, if they choose to accept that mindset, that's fine. If they don't, well, then that's okay as well. I mean, that is how they are.
Yeah, and I think we've got to support them. I think
yes.
again, patients may, feel embarrassed or don't want to have that conversation because they feel like they're failing us in some way because they can't take that tablet. And I think hopefully this podcast is quite demonstrating
yes.
is that we are treating you as a person.
Yes.
We understand what these tablets can do, but there's ways that we can manage it and support you.
Absolutely.
Whichever decision
yes.
you want to take.
There is evidence that shows it will improve your outcomes from your cancer, but we want high quality of life while you're on it. And as Tony said, the debate around HRT is so vibrant at the moment because there isn't any definitive data on it.
I mean, it's been a very interesting debate over as long as I can remember, so that goes back a long time. I mean, there was an MP whose name escapes me, who was on HRT and wanted everybody to have it. It was the best thing since sliced bread. And there is a school of thought that and of course it stops you getting dementia now and all of these things, so it's everything through to the other school of thought, which is it is the work of the devil, and probably a male devil as well, that is being done to women, and it's terrible. And it's like all of these, well, the menopause is natural. So was smallpox, it's
very good point. Yeah, and again, it keeps coming down to that individual and how that individuals experience it. You get two people who will go through all this, and say.
I love this one because people are individual. Everybody's, and occasionally I get this bit when we're talking about treatment. So, what would you tell your wife to do? And I say, well, I know perfectly well I wouldn't tell my wife to do anything because the response would not be positive. And anyhow, if I thought it was the right thing for her to do and I told her to do it, I know she wouldn't do it. So, but because people are individuals.
Yeah.
And
I think one thing that patients particularly struggle with is, as you say, we very informally, very casually hand over a tablet.
Yes.
Brilliant, you don't need any further surgery, congratulations, lymph nodes clear or tiny traces, here's a tablet to take, this is what we would recommend for you. And I think patients, because of maybe breast cancer survivors in the media, people who've potentially bounced back from their breast cancer treatment, Kylie Minogue wearing her gold sequin hot pants on stage, I mean, all credit to her, wow. But unfortunately, that has altered patients' expectations after their breast cancer surgery and their management. And then we put them on a tablet. And as you say, there's a hump. Those first 3 months are the hardest. We know that.
Yes.
And if they can stick with it and get through that, we know that compliance is better in the long term. But actually, I really think it's about managing expectations and the psychological trauma of being diagnosed with a cancer. The dust is not even settled after 6 months. They've had surgery, they've had diagnosis, they've had surgery, they're going for radiotherapy, they might have had chemotherapy. The psychological trauma that's having to take place as well, the adjustment to that, as well as throwing in a tablet into the mix, as well as seeing amazing people in the media post on their post-cancer journey. I think these women are faced with so many challenges.
I think that is a difficult one. I mean, it's the other side to that coin, which is seeing. I mean, certainly my experience was when Linda McCartney died. That was a real blow to so many breast cancer patients because they thought, well, if she can't survive, how can I?
Yeah.
And when I talk to them about that, I say, we keep our fingers crossed for Kylie. But it is.
And we see when any celebrities being diagnosed or something happens to them, we see an immense spike in patients coming through.
Quite rightly, and I'm pleased they do, because there's a breast cancer awareness campaign. It's a perfect campaign. But there's a lot of anxiety.
Which it creates, for those, it's great awareness, but for those who have been diagnosed, it's another one of those, oh my God, this could...
I mean, it's an interesting one because we talk a lot, and patients talk a lot, quite rightly, about quality of life. And when I used to teach medical students, I used to say to them, can you define quality of life? And that's quite an interesting one. I mean, the best definition I've come across, it wasn't mine, I hasten to say, is your quality of life is how close your experiences come to your expectations.
Brilliant.
Because that puts two elements to it. Because I'm old enough to remember my parents saying how great it was during the war times. And of course, if you think you're going to be blown to bits at any minute and you go and have a great knees up down at the pub, it seems wonderful. Equally, if if you think you're going to die very rapidly and you get a few symptoms, that may not be too bad. If, on the other hand, you're trying to live life normally and these symptoms are really, and to some extent, the fear of death has begun to recede a bit. I mean, I used to say that to patients having radical radiotherapy for gynecological cancer, which does produce some, and I used to tell them about all the side effects, and of course, they thought they were going to die. They said, "Oh, you do whatever you like." And I used to say, you do realise that although we're going to do the best we can, hopefully you will be well and okay, you may get some nasty symptoms, and we will go through what those were. And in 5 years' time, that may seem, worse. And I said, the best I can come to it from personal experience is, if you have a major high-speed car crash and you walk out of it unscathed, you think, that's brilliant, I'm okay, nobody's been killed. If you then, a few days later, you think, I've written the wretched car off. And people's views do change as time goes by. And to some extent, you give them the I'll take this tamoxifen or whatever, aromatase inhibitor, and then a few months later, they're feeling absolutely awful. And it's to try and help them through that, which is a bit of what you were saying.
Yeah, absolutely. And managing those expectations from the outset.
Yes. Yeah.
And I know we try to in clinic, and I always feel a little bit like a doom merchant when I say, okay, so I'm going to give you these tablets. Loads of ladies tolerate them really well. However, there's a small subset of patients that don't. But it's about managing those expectations. And then if they don't feel dreadful on it, they're winning.
Yeah, I have to say, what I say to them is, most people tolerate these very well. And of course, if you're one of those who don't, first thing you're going to have to put up with is being told how well everybody else tolerates them, which is true.
Like, I've had phone calls where patients are worried that it's not working because they haven't had those side effects.
Well, that is. I mean, I remember.
That's a really important take-home point, actually. Yeah.
As a very my first experience of oncology as a very junior doctor, and in those days, chemotherapy used to make people very, very ill. So ill that they would vomit when they saw you, which was a bit bad for the self-esteem. But I remember one patient who was having a terrible time. She said, I look at it like this. If it's making me feel like this, just think what it's doing to the cancer. Which is a little bit like, I don't know if you remember the advert for Domestos that kills all germs dead. And you think if they could say, and they die in screaming agony as it, this caustic fluid tears off their bacterial coat, they would have done. But we do sort of rationalise things along those lines.
Isn't it? It's
and people think, I'm taking this, it's not causing me any ill effects, can't be working then.
Yeah. And there's so many more women we know that are taking it and that don't have those side or have them, but they manage it. They understand that a lot of them who are perimenopausal, they would have received those side effects anyway. I know the difference with sometimes when we kind of chemically induce it, it's more like a smack in the face rather than a gradual a gradual fight. But there's going to be peaks and troughs, but there's peaks and troughs regardless if you had a cancer or you didn't have a cancer. We're going to have aches and pains as we get older. We're going to have more comorbidities, and it's it is part of life as well, and it's
No, I mean, I think, as you say, I mean, one of the things that's come about, a lot of the stuff about menopause that's around, which is good, is that there are an awful lot of adaptations that can be done in the workplace and what have you, that can make quite a big difference. Yeah. And getting people away from that menopausal woman, which is not a helpful attitude, to what are the things that we can do that enable you to work well and feel okay through this time. And the same really applies to the women who are having endocrine treatment. I mean, one of the ones which I find quite hard is there is evidence, quite good evidence, for premenopausal women who have estrogen receptor positive cancer at relatively high risk, that ovarian suppression does, along with their endocrine treatment, does improve or significantly lowers their risk of recurrence. That's not an easy ride, though. It's not an easy. We tend to concentrate that, you're going to have a quite large needle stuck in your tummy once a month to give the injection, which is, that's not too bad, and the nurses are very good at doing it. it's the other bits that are bad, because it
okay.
gives them sort of menopause on steroids, which is
Well, that's and
which
it's a
is
completely different experience.
it is a
isn't
different experience. Now, again, it may be something they'll say, yeah, I'll go through that because I want to be as certain as all sorts of reasons. I've got young kids. I've got to be there. I've got to do this, and that's okay. But for other people, it's just a nightmare.
Yeah.
And it is listening to where they're coming from, giving them the facts, and then taking that on board.
So I think take-home messages are, on the whole, endocrine treatment is well tolerated
Yes.
for our patients.
Yes.
There are things we can do to help our patients with their endocrine side effects.
Yes.
That don't increase your risk of recurrence, and vaginal estrogens being some of them prescribable alternatives to HRT, and so we can empower our patients with that knowledge. But those patients who are also maybe withdrawing from HRT that we've asked them to stop because they've been diagnosed with a breast cancer, again, they're also relevant. All that advice is relevant to them as well. So I think, on the whole, it's well tolerated, but actually there's things we can do to help these patients.
I think the other bit is, the NICE guidance says that for women who have severe menopausal symptoms, who have breast cancer, that if you've tried the other things, HRT should be considered and the risks should be discussed with the patient. So it shouldn't be you can't have it. We can't say that you can have it and that it necessarily can't increase your risk, although the level of evidence suggests that the increase in risk is small, and certainly of dying from breast cancer is small, and have that discussion. For the patients whose symptoms are controlled by the things you've just mentioned, then it's not a problem.
Exactly.
But for those for whom it's not being controlled, for some of them, I should rather be dead than carry on.
Absolutely.
Actually, having HRT is not likely to make you dead, and it may make you feel very, very much better.
And so I think it is, it's out there as an option. I think it's down the list, and it should be kept down the list. We have alternatives we should try in the meantime, but it's definitely not ruled out. I'm liaising with our gynaecologist locally at the moment. We want to set up a dedicated service, so actually GPs can be confident in sending patients to this specialist service in order to obtain specialist advice. This is a very nervy area for GPs, and I completely get it.
Absolutely.
And so actually having some specialist advice from both the breast team and a specialist menopause gynaecologist actually would be fantastic.
There are huge areas, increased areas in medical care of all sorts, where putting together people with a particular problem that is not every day with people who are specialised in it, gives them the support which you've just mentioned, and also it actually helps develop better treatments, and it's even the base for doing some better research.
Definitely.
So I think all of these things would lead to improvement for these women, and they don't deserve it any less than anybody else.
Absolutely. So watch this space.
Yes, and if you are having problems with the endocrine therapy and you want that little bit additional support, then please get in touch with your breast care nurse, and they can refer you on to one of the virtual clinics that we have, so you can sit in the safety and confidence of your own house, and you don't have to participate, but listen to some of the ladies, and you might find something that actually can help. So that there's help out there, and and you can say by our fantastic specialist services that we'll do all I can that we can do to support you with this. So thank you very much both for coming today. It's been really enjoyed it and very informative. So thank you very much.
Brilliant. Thank you.